Good evening or good morning, depending on where you are in the world. It is such a pleasure to join the conference, and I thank the conference organizers for giving me this opportunity. My topic is cancer survivorship, and I'd like to start, next slide, please, by introducing a few of the points that I'd like to discuss this morning. I think we need to talk about the role of oncologists in providing post-treatment care to cancer survivors, to discuss and review current general cancer survivorship principles and guidelines and associated barriers and issues, the post-cancer treatment effects that are both psychological and physical, and how to effectively manage them, and to discuss current preventative health recommendations for cancer survivors. So let's start with guidelines. And one of the big challenges, I think worldwide, I would be very interested, of course, in hearing what you face in the Philippines, but I have traveled and I have spoken to colleagues all over the world, and I know that delivery of care to cancer survivors remains a challenge. There are many different models, and we have to start by asking ourselves, who are we talking about? So at least now, the working definition that I hold at my institution, currently Stanford, and that most of the organizations that are thinking about this and are putting forth guidelines use, is that anybody with a history of cancer is considered a cancer survivor. In other words, the inclusive definition of a cancer survivor is any person who has received a diagnosis of cancer from that point forward for the rest of their lives. So in the inclusive definition of cancer survivor, a person living with metastatic cancer can also be considered a cancer survivor. So individuals living with, through, and beyond a cancer diagnosis are all considered cancer survivors. But of course, if we think about it in those terms, we lose track of the real issue in front of us, which is what happens to people with cancer after they have completed active treatment, but continue to experience long-term effects from the cancer treatment, remain at risk for late effects of cancer treatment. And those are the people that we normally think about when we think about cancer survivors and delivering care to them, because they really are a special population, and thinking about their needs puts us in a field that's somewhere between oncology, primary care, and palliative care. There's another group that I'd like to bring to your attention. We are all oncologists who take care of adult patients. Maybe in the audience, we have some pediatric oncologists, and you will understand this as well. But the adult survivors of childhood cancer are a very special population. They are perhaps a smaller number among the ranks of the cancer survivors in the US. Just to give you an idea, we think with this inclusive definition that we have about 18 million cancer survivors, and about 500,000 of those are the adult survivors of a childhood cancer. They have lifelong risks that are very different than their peers or age-matched peers. And there's wonderful research from two studies, mostly the St. Jude's Lifetime Cohort and St. Jude's Life. And these are amazing sort of repositories of data. They have done such an amazing job in following kids, not only treated at St. Jude's Hospital, but at many other centers in the US that take care of children with cancer, and have followed them into adulthood. So for that particular population, we have a lot of data. More and more is emerging all the time. And there are very specific guidelines to take care of them. And that allows for this risk stratified care. And the problem with trying to think about risk stratified care for adult cancer survivors is that it's much more complex, because older cancer survivors, and that's the majority of the group of cancer survivors, also have comorbidities. It's not just the late effects of cancer treatments that constitute their risk, but they also have and bring with them many other diseases. So there are many models that have been described involving cancer clinicians and primary care physicians, of co-management, share management, of interdisciplinary, multidisciplinary management. And, they're all fine. Care coordination is really the issue, especially at points of transition for the patient, such as the completion of active therapy. And that involves information, education, and self-management for the patient, because ultimately the patient needs to know who to call, what to call for, when to show up for visits, how to better take care of themselves. But it also requires education of primary care clinicians and systems that allow for exchange of information in real time on behalf of the patient between the different professional groups. So there are two points that I would like to make to, again, drive this point home. In the world of cancer survivorship, one of the first ideas that emerged mostly from the people who were doing research on how to follow the adult survivors of childhood cancer was that there should be a plan, a document, and a treatment summary. And that document should be shared with the patient and the primary care physician. It's prepared by the cancer clinician and should contain the information that they need in order to have effective post-treatment care, including the types of drugs and dosages, the types of radiation, the field and the dose, and whatever surgical procedures the patient had. Knowing that and who performed or who supervised those treatments would then allow for the very clear recommendations that say this person needs these many scans, these many physical exams at such and such frequency. And with that, the receiving clinician with the patient can make sure that everything is done according to plan. The problem is that it's very laborious to prepare these survivorship care plans. And when they have been rigorously studied, they haven't really delivered the great solution to the problem. At least in the US, often these care plans don't reach the primary care physician, or the primary care physician finds it difficult to follow. So the survivorship care plan remains a wonderful tool, but is not the solution to the entire problem. We have guidelines for cancer survivorship, and the ones that I would recommend that you familiarize yourself with are those from the NCCN. They're very comprehensive, too comprehensive. So they are voluminous. They're frequently updated, which is fantastic. They really are the process is very collaborative. I sit on that guideline panel, and I can assure you that we discuss all of the data and we try to, distill it so that it is useful for our colleagues. But it is also intended to be used as general survivorship guidelines with disease-specific guidelines. It includes recommendations for symptom management, psychosocial syndromes, and rehabilitation. So in other words, if you are following cancer survivors, you have two sources of referral materials that are very comprehensive: the disease-specific guidelines and the guidelines in general for cancer survivorship, where you will find recommendations for treating insomnia, or treating fear of cancer recurrence, or treating cancer-related infertility, for instance. Next slide, please. So the NCCN guidelines can be accessed for free. You will land on this page that says survivorship, and these have just recently been updated. So there are 2023 recommendations, and I suggest that you play with that a little bit. And on the left here, I show you also that there are templates for providing patients with a survivor care plan that are short. The American Society of Clinical Oncology, ASCO, has on its website and on the website for the public, cancer.net, these survivorship care plans. You can adapt them You can put the specific items that you recommend for follow-up of the disease, perhaps that you're following patients for, if you are a specialized oncologist, or just use this as a general guideline. But these are all tools that are available to you and are for free. So one of the issues that is very important and remains very important in cancer survivorship is the patient-facing resources. And I think that is also something that I wanted to draw your attention to, both the NCCN, which is a consortium of cancer clinicians, and ASCO, a professional society, again, with a website for the public, have tools that you can download and provide to your patients. These are workbooks, so patients can write in them. The ASCO one, for instance, helps a patient prepare their own cancer survivorship care plan. And it also provides a lot of information and resources about all of the common problems and syndromes that cancer survivors experience. So let's talk a little bit about the pain points, the barriers to survivorship care. Again, a lot of my comments are based on what I see in the system that I work in the US, but they apply, I think, to many other societies as well. In the US, one of the big problems is what I'll call the fragmentation of care. And that means that a patient may travel to a cancer center or to a practice to receive their cancer care, but that's not where they're going to receive their primary care. So there are problems, for instance, with distance that the patients have to travel. There are problems finding primary care physicians who have access to the cancer records. There may be a lack of knowledge about the need for longitudinal care, and also a lack of knowledge about what cancer survivorship really is. And many primary care physicians, when they've been surveyed, say that they're just not comfortable taking care of cancer survivors. They think they see the word cancer and that belongs basically to the oncologist. And what we need to do is find that middle ground. So cancer survivorship, as I said before, focuses on needs and experiences of any person living with, through, and beyond a cancer diagnosis. So that it includes palliation, prevention, and health promotion. And this is the wisdom of Patty Gans, who is one of the founders of the field of cancer survivorship. So let's talk about what the common post-treatment problems are really. Pain. We often don't think that that's a big problem, but depending on what surveys and what data you read, maybe 1/3 to 2/3 of patients experience post-treatment pain, post-cancer pain. There are many complications that are organ specific. Perhaps the emerging field is that of cardio-oncology, because so many of the treatments really impact on heart. And cardio-oncology, I think, is probably a fascinating example of a field where another group of specialists have joined the ranks of the oncologists to think about how to deliver care, both treatment-related care, but also for prevention of future cardiac problems. Lymphedema, as you know, is a major problem and, of course, depends on the site of disease. Fatigue and insomnia are common and persist for years after cancer treatment. Chemotherapy-induced peripheral neuropathy is an important syndrome that for some patients resolve in a year or two, but for some remain. Ototoxicity from certain cancer drugs, certainly bone health is affected. I'm a breast cancer doctor, and I think that we need to be very familiar with the complications of treatments that induce early menopause, for instance, or cause estrogen deprivation, because this may lead to osteoporosis. Cancer-related cognitive dysfunction is something that our patients tell us about, and we often don't know what to do about. So that's also something that is very important in this particular field. Body dysmorphia, meaning that people don't really feel comfortable or cannot even look at themselves in the mirror. And again, we all have anecdotal experiences of patients saying that they just can't even take their clothes off and look at themselves. That really can become a huge problem for them. Problems related to premature menopause, intimacy, sexual health, fertility, and reproductive concerns, especially for those younger patients. And then the psychological syndromes of fear of cancer recurrence, PTSD, anxiety, depression, and even suicidality. This is a very complex list. And again, it lies somewhere between oncology, palliative care, and preventative care. So late effects of cancer treatments are those that occur after cancer treatment, whereas long-term effects are those that occur during cancer treatment and persist. Specific treatment exposures are linked with specific late effects. These are the types of things that in cancer survivorship, we need to think about all the time. What exposures have our patients had? How old were they when they were treated? How many years has it been since they were treated? And so this is the kind of information in the intake that we need to have, and then we can look up and provide a plan for following them. If they've been radiated, they're at increased risk perhaps for second malignancies in the radiated field. They may be susceptible to a skin cancer forming in the radiated field, but we need to know what it is that they were treated with and when. So the care of the cancer survivor includes surveillance for cancer spread or recurrence, which we do in oncology, and screening for subsequent primary cancers. It involves monitoring of these long-term effects of cancer, including psychosocial, physical, and immunological effects. And the latter are emerging more and more with patients now treated with immunotherapy. Anecdotally, I just heard, for instance, of a young woman who was treated with immunotherapy for triple negative breast cancer, who was in great shape, had a great response to her neoadjuvant treatment, but previously a marathon runner. She now is on oxygen because she has pneumonitis, which persists from the use of the immuno-oncology drug. So these are the new kinds of challenges that we'll have in caring for cancer survivors. We need to think of prevention and detection of late effects of cancer therapy, and the cardiac prevention, for instance, is a perfect example. We need to evaluate and manage any cancer-related syndromes and think about appropriate referrals. We may not be able to manage the sexual health and intimacy issues, but we may refer to colleagues with experience and with interest and in sex therapy, for instance, or to a reproductive endocrinologist if there are issues with family planning. So essential to this is the coordination of care, and we need people who really are experienced in this area to be the quarterback, so to speak, of the cancer survivor. So the NCCN recommendations, for instance, are very general, and I think you'll find everything on this list really is better handled by primary care physicians. For instance, physical activity, what to do. Nutrition is top of mind of cancer survivors, I think, worldwide. How do we do this? What do we tell them? What do we do about alcohol? And you'll see that the recommendations usually say to try to avoid or drink sparingly. These patients often need immunizations, especially after immune suppressive therapies like a bone marrow transplant. Cardiovascular risk needs to be assessed, and perhaps they need special tests for these. And of course, mental health, distress, anxiety, depression, and so on are very, very essential. Next slide, please. So next slide, please. So preventative health is an area where, again, this is expertly handled, in my opinion, by primary care physicians. And that's why, in my opinion, again, it's so important worldwide to establish these collaborative alliances and educate our primary care physicians to take care of this population. Of course, preventative health is age-adjusted and risk-adjusted. So depending, again, on exposures, bone density monitoring for women with early menopause, for instance, or those on endocrine therapies, we also need to update family history and genetic risk because we know more about genetic risk all the time. And because sometimes in the rush to treat the cancer, patients have not had the opportunity to really think, or perhaps they weren't ready to really think about their genetic risk and what to do for themselves and for their families. Vaccinations need to be taken care of, and certainly interventions focused on physical activity, smoking cessation, alcohol intake, nutrition, and stress reduction or treatment of stress-related syndromes, including perseverating thoughts about cancer recurrence or insomnia, which are very common among cancer survivors. So with that, I think I have come to the end of my time, and I would be absolutely delighted to take questions or to learn more about what is on your mind about how best we can all care for this growing population.